Hello, my name is Monique, and in my group we have Alicia, Anthony, and Mansoor. This is our case study 3 for our group assignment in EXS306. In our presentation today, we are going to cover a few of the different topics. One will be the background of the case problem, potential mechanisms for injury, patient details, subjective examination, objective examination, assessment findings, rehabilitation, and a management plan. The case under investigation involves Mr. B, who was recently playing cricket when he experienced a sudden burst of intense pain in his shoulder during the match. The pain is apparently situated posteriorly within his left shoulder, and upon his initial meeting with our team, it was discovered that the pain is inhibiting his range of motion when performing daily tasks such as showering. He has agreed to visit us at least once a week for the next 2 months of his rehabilitation program if deemed necessary. Whilst we did not have access to the full clinical report from his physiotherapist, during the interview, Mr. B recalls that his physio stated there is a potential grade 2 strain located somewhere within his left shoulder. According to the clinical grading system for strains, a grade 2 strain refers to extensive damage and tearing to groups of muscle fibers, excluding complete ruptures. Symptoms of a strain can be characterized by local pain, moderate swelling, disability, and a painful range of motion in an affected arm, which usually results in approximately 10 to 25 degrees of deficiency in the patient's movements. With the information provided so far, we proceeded to review the current literature surrounding cricket bowling in order to identify potential mechanisms for catalysts for Mr. B's injury. A quick analysis of the biomechanics within overhead bowling was conducted. A research article revealed that during cricket, bowlers are required to coordinate specific upper and lower limb movements in order to properly bowl towards their desired targets. Simply put, cricket bowling involves building up momentum by running towards the throwing line of the converting said momentum into circumduction of the arm for effective ball delivery. The kinetic chain or sequence of movements within throwing can be visualized in the simplified image above. The list of movements starts off with a stride, following by pelvis rotation, followed by upper torso rotation, followed by elbow extension into a shoulder rotation, before finally wrist flexion. It is believed that at the point of maximum shoulder rotation, in this case prior to immediate ball release, the shoulders are susceptible to injury. This is due to surrounding musculature eccentrically stretching to compensate for torque forces. Similarly, following immediate ball release, the rapidly moving throwing arm needs to decelerate with the body. Muscles produce large compressive forces to resist joint dislocation. Due to the nature of the sport and constant need to produce maximum throwing force when covering long distance or fast bowling, the repeated overhead throwing actions can result in degenerative changes in the shoulder joint. In our case, Mr. B may have developed tense muscles from overuse and lack effective recovery resting techniques. It is possible that during the shoulder rotation phase in throwing, the sudden jerk and explosiveness in his movements caused an overload in tension within his posterior rotator cuff muscles, such as the teres minor, the infraspinatus, resulting in a sudden tear. We wrote down the patient's details in order to get an understanding of his history. He is a 36-year-old male. He is 176 centimeters and he weighs 80 kilos. He is left-handed and he wishes to participate in his upcoming cricket season. Next, I will be talking about the subjective examination. The subjective examination form will be used and the body chart indicating the location of the pain. When Mr. B was approached in the waiting room, it was observed that he had a poked out neck, slouched and rolled forward shoulders. We introduced ourselves to Mr. B and began asking him how we could assist him today. He reported a deep, dull, aching pain on the left posterior shoulder when he was at rest. For example, not moving his arm to undertake any activities. He reported the intensity as 4 out of 10. He also mentioned he feels aching, sharp pain when he moves his arm during normal activities. He reported an intensity of 7 out of 10. He advised us that he is left-handed. When asked about the factor or functions that aggravate the pain, Mr. B mentioned that he moves his arm away from his body. He feels the pain and he struggles to engage in activities, such as reaching up to grab something from the cabinet over shoulder height, washing his hair, putting his shirt on, lifting loads as shopping bags, or even pushing and pulling. The next question we asked was about severity and irritability. This is important because it will allow us to determine the symptoms that restrict movement and function, which is important when we complete the physical examination. He mentioned when he undertakes normal activities such as reaching up or washing his hair or putting his shirt on can cause him severe pain. Severe pain is a certain point due to a movement that cannot be held in one position. It is important to know that what movement causes pain and continues to be present for some time before his pain is gone. He mentioned when he moves his arm away from his body sideways and from the front, abduction and shoulder flexion, and returns to normal position in his hand. His aching pain disappears after a couple of minutes, but it's deep and dull. To understand what makes the pains better or at ease, easing factors is asked. Mr. B mentioned that he iced his shoulder using a cold pack after the game and that eased the pain. This is indicating some inflammation is reduced. His physiotherapist issued him with a shoulder brace to mobilize his shoulder. He wears that when he is at home for the time being. Improving static or worsening. The pain compared to the onset while playing cricket has improved, but again aggravated when moving his arm. Mr. B reported he had difficulty sleeping last night on his left side and could not sleep his usual way of having his hand under the pillow. When he woke up today, his shoulder felt stiff, limiting him to brush his teeth. These are some of the special questions we went through with Mr. B. His general health seemed pretty well. He didn't have any underlying diseases, which was good, and he wasn't on any unusual medications. We came to a conclusion that he had a pretty good overall health. Mr. B said he was throwing a ball from outfield when he had a sudden pain on his back left shoulder, and he did not hear any snap or cracking noise. He then changed field positions into the infield. Once the game had finished, he applied ice on his shoulder for 15 to 20 minutes every hour. After the game, he still had pain and made the decision to go to the physio for a diagnosis. His physio said he had a grade 2 strain but forgot the location of the strain. The physio issued him with a shoulder brace for immobilization. Some of the past medical history that Mr. B had was minor bruising during cricket games or on the field, or batting from impact of the ball. Otherwise, no history of medical diagnosis, accident or surgeries. His social history: he's a 36-year-old and he is a high school English teacher. He is married and has 2 kids under the age of 5. When he has time, he cycles with his friends. There is no family history of any diseases or medical conditions for Mr. B. He is motivated to participate in rehabilitation so he can then go and play cricket with his friends and during the season. On the first meeting in the waiting room, it was evident that Mr. B had his head tilted forward and his shoulders rolling forward also. On the formal observation, Mr. B had his head tilted forward as well as his left shoulder slightly anterior rounded, slight kyphosis and lordosis posture, slight degree of anterior pelvic tilt and a slight elevation of scapula. No muscle wasting was observed. When palpating, there was no sign of swelling at the acromaclavicular joint, sternoclavicular joint, and cervical spine. Lateral clavicle was elevated. Slight swelling was observed on the proximal bicep tendon on the borders of the acromion. Tenderness was observed on the anterior lateral acromion. The pain was reported on the acromion head and humerus during palpation. No visual signs of atrophy. To understand how much range of motion is restricted due to the injury, we can compare both slides. In this particular case, active movement was not tested due to pain. While conducting a passive range of motion test to evaluate integrity of glenohumeral joint, pain was indicated during flexion, abduction, external rotation, extension, internal rotation, and horizontal abduction. During this assessment, the scapula was elevated, increased upward towards rotation, increased protraction, and an anterior tilt. We then completed an active function test to determine what structure within the shoulder region or glenohumeral joint was injured. 90 to 120 degrees painful arc test was positive. All of the rest of the tests were positive except lift-off test, which was negative. Belly press test was also negative. We suspect a possible rotator cuff grade 2 strain. It is only through rest that an injury is able to return to its original state. However, through rehabilitation programs and management, we are able to condition and speed up the process of repairment. A rotator cuff tear is one of the most common diagnoses of shoulder pain. Depending on the thickness of the tear will determine the amount of time required for rehabilitation that can vary from 6 to 12 weeks. Through mechanics of exercise, the fibers within the muscle and tendons respond positively and commence healing agencies. The client has provided us with a time frame of 2 months where he will meet with us for a clinical session once a week, as well as performing out stretches and tasks in his own time. Throughout the 8 weeks, we will be constantly reassessing range of motion whilst breaking down week by week and introducing new stretches alongside different approaches to training. All learning purposes are to engage the progress of all four muscles of the rotator cuff as well as surrounding muscles. The goal he has set for his rehabilitation is to be getting back out participating in this year's cricket season without experiencing any discomfort. Week 1 is education and inspection. We will assess the range of motion and palpate. Educate on the potential provoking postures and movements. We'll retrain the movements and we will get the client to ice for 20 minutes every 2 hours, keeping the injured shoulder in a sling. In week 2, we'll introduce mobilization. We'll assess the range of motion once again, introduce the exercises involving minor movement, passive movement only, focusing solely on stretching. All exercises are to be demonstrated first, and then once we have demonstrated them, he will then take them home with him and practice them at home. In week 3, we'll enhance the stretching skills, assess the range of motion once again, introducing active movement alongside passive assisted exercises, revisiting of the week 2's exercise with introduction of new exercises. Week 4 will be enhanced stretching once again, assessment of range of motion, revisiting week 3 exercises and assessing the progression, assisted exercises of active movement, introduction of moderate locomotion, assessment of all exercises learnt, focusing on analysis of progression of movement and comfort during the isometric exercise. Moderate intensity walking 30 minutes a day for 5 days a week. Week 5, 6, and 7 are all focusing on increasing the range of motion whilst building up resilience to resistance throughout day-to-day actions. Small levels of assisted resistance gained through bands and weights will be incorporated to previously learned exercises. This is to not increase muscle mass, but to slowly strengthen the muscle for daily activities like picking up an item from various heights. Finally, during the final 8th week of management, performing previously learned exercises except adding some minor form of resistance, the client should be performing majority of the active movements now comfortably. All forms of contractions should not be causing a significant amount of discomfort, and fluidity of movement should be stable. If the client has completed all of the above set exercises, they should then be referred back to their physiotherapist for a final examination. However, if the level of movement still isn't being achieved, it will be advised that the client continue to an additional 4 weeks of management to secure efficient movement, flexibility, and contractibility. In this case study, we have learnt to diagnose the rotator cuff injury, how to put together a management plan for the rotator cuff injury, how to test the muscles to see if it is a rotator cuff injury, and how to assess the injury of any shoulder.